Objectives are shown here, provide some updates about the RAS and about targeting it with pharmacotherapy, and then relate it a little more specifically as a nephrologist to chronic kidney disease with proteinuria. I'll start by showing you, though, a view from our children's hospital in the outskirts of Denver. This sign that you can't really read in this angle says Children's Hospital Colorado. So you're looking from Children's Hospital Colorado, the 8th floor or the 9th floor west, across the medical campus that we're on. So this complex here is the adult University of Colorado Medical Center, and it's obscuring the view onto downtown Denver. So if this building wouldn't be there, you would see the skyscrapers of downtown Denver 5 miles or so west. And then, of course, in the background there's our drinking water in the form of the mountains, the Rocky Mountains, and you can see the snow almost year-round on these peaks, which are up to 14,000 feet, so 4,000+ meters high. Now, just to clarify the partial joke in my title, there are good reasons why ACE inhibitors shouldn't be added to the drinking water. The most important one is shown here, actually by work done by one of my mentors when I was a nephrology fellow, and one of my friends and colleagues who was a fellow when I was a fellow as well. The Renin-Angiotensin System actually has quite an important role in kidney development. And so if you block the renin-angiotensin system in a pregnant mother by treating her for hypertension with an ACE inhibitor, for example, then her developing baby will have all sorts of things potentially come out wrong as far as the kidneys are concerned, the baby's kidneys are concerned. My friends focused on the development of the ureteric bud and the renal collection system as far as the importance of the renin-angiotensin system is concerned. So you can see in all kinds of models here knockouts of all kinds of components of the renin-angiotensin system. You can see a hypoplastic renal papilla compared to a normal kidney. But those effects on the developing kidneys go further than that, which is summarized in this table. And you can see there are all kinds of abnormal renal phenotypes beyond the papilla and the collecting duct that have been described in various abnormal, which basically is the substitute for pharmacologically blocked in a pregnant woman, abnormal components of the renin-angiotensin system. The other reason why ACE inhibitors shouldn't be added to the drinking water is because even though it's called angiotensin converting enzyme that's inhibited by these drugs, angiotensin converting enzyme is also involved in the metabolism, and specifically in the breakdown of bradykinin. And so in some individuals, this breakdown of bradykinin that requires angiotensin converting enzyme is inhibited enough by ACE inhibitors for these patients to have complications from too much accumulation of bradykinin that no longer is metabolized, and those patients can develop angioedema and related milder symptoms like a chronic cough. And so those should be two good enough reasons to not add angiotensin converting enzymes to the drinking water. The renin-angiotensin system, as we probably know it and learned about it in medical school, is shown here, and there are various ways to interfere with it, most commonly obviously with ACE inhibitors such as enalapril or lisinopril. There are other more recent drugs, more recently developed drugs that will also interfere with the renin-angiotensin system, or at least with parts of it. The angiotensin receptor blockers like losartan or candesartan are one example. Renin blockers have been developed and are partially in clinical use. And of course, we've had aldosterone antagonists for a long time. Especially keeping in mind that the renin-angiotensin system is triggered, at least historically, how we've been taught, by anything that decreases renal perfusion and then is supposed to compensate for that. It's not surprising that if one blocks the ability to compensate for decreased renal perfusion with any of these agents, especially ACE inhibitors, that one of the side effects of these drugs obviously is also persistent decreased renal perfusion and therefore a decreased glomerular filtration rate and hyperkalemia. Now, we nephrologists don't give up easily, so we almost still, despite all these problems and risks, we still would like to add ACE inhibitors to the drinking water. One of the, or a pair of important reasons are the well-known and well-described antiproteinuric effects of these drugs. And of course, the other well-known benefit of these agents are their blood pressure lowering effects. But what we now know about the renin-angiotensin system, because our cardiology friends taught us and other colleagues taught us, is that it is much more widespread, complex, than we used to think 10 or 20 years ago. We know that the renin-angiotensin system has an important role in cardiac remodeling and in the development, or if treated, regression of left ventricular hypertrophy. But there are also all kinds of other effects that have to do with the renin-angiotensin system. Two examples here are, there is a renin-angiotensin system in the central nervous system. There's also renin-angiotensin system involvement in the immune system. And so the current thinking about the renin-angiotensin system actually isn't so much that it's one system, but that because of its pleiotropism and of the more recently described paracrine effects of components of the renin-angiotensin system, that there are actually not only a systemic, but also a number of local renin-angiotensin system to sort of make us want to use the plural and say this is actually more than one system or a whole network. But back to the old days where it was mostly all about chronic kidney disease and proteinuria. Giuseppe Remuzzi is a very famous adult Italian nephrologist who for decades gives the podium talks at our nephrology meetings and writes review articles in journals like the New England Journal. This one is almost 20 years old now, and he proposes a very impressive chain of events that begins with any kind of renal injury and then involves glomerular proteinuria. So most of what we know is about glomerular proteinuria, which means albuminuria, and then involves problems at the level of the tubules as well that have to do with that glomerular proteinuria basically injuring those tubules and leading to tubular interstitial damage. And all of that then culminates in renal scarring and progression of whatever kidney disease started this cascade. To quantify this a little bit and give you a little bit of a hands-on tool to grasp proteinuria, in this review article, Remuzzi and his co-author introduced the protein to creatinine ratio on a one-time random urine sample as compared to a 24-hour urine collection, which of course is more complicated, more difficult to do. And they showed that depending on how much extra protein somebody has in their urine, somebody with chronic kidney disease, there's a prediction that you can make regarding GFR decline, meaning how quickly that person's proteinuria chronic kidney disease is going to progress. And at least 20 years ago, it seemed like as long as the protein to creatinine ratio wasn't much higher than 1, there was very little risk of progression. But with increasing degrees of proteinuria, the risk of GFR decline and acceleration of GFR decline obviously increased quite a bit. Now, what's the normal protein to creatinine ratio? It's less than 0.2, meaning if you want to know how much protein one of your children has in their urine and they can pee in a cup, then you can send that sample to the laboratory and say, tell me how much creatinine and how much protein is in that urine sample. And at least for children older than 5 or 6 years, if that random urine sample has 100 milligrams per deciliter of creatinine in it, then it is not allowed to have more than 20 milligrams per deciliter of protein in it, because that would make the ratio 0.2. So this between 0.2 and 1 gray zone may or may not be, at least based on this, probably may not be associated with a progression risk of disease. And in adults, a protein to creatinine ratio of around 1 represents just about 1 gram of protein in a 24-hour urine collection. In children, it's a little more complicated than that. But the bottom line is that based on these data, reducing proteinuria by Renin-Angiotensin System targeting can delay GFR decline, and that delay is partially, not completely, related to improvements in blood pressure. Now, 20 years later, last year in November, Dr. Rimuzzi was still writing review articles in fancy journals, and so everything is in color now, including our GFR staging system. We have chronic kidney disease stages 1 through 5 based on what a patient's glomerular filtration rate is, and we further stratify each of these stages based on how much proteinuria there is, and so the risk of disease progression and ending up on dialysis obviously is the worst if there's a lot of protein in the urine in somebody who has already pretty advanced chronic kidney disease. And this is a problem worldwide. This shows you how many people in each country that was surveyed and returned the survey are on dialysis. So end-stage renal disease is somewhat of an epidemic, and especially in areas of the world where chronic dialysis is readily available, there are a fair number of people on chronic dialysis. The pathophysiological model hasn't changed very much. It still starts with proteinuria, and then tubular injury, and then fibrosis, scar formation, and therefore further loss of kidney function, progression of chronic kidney disease. What has changed a little bit is what is being said about how much proteinuria can be tolerated, when do you want to start treating. Like I told you a few slides ago in that first review article, when I said a protein to creatinine ratio of below 1, while not normal, may not be particularly risky. That has changed. I didn't put it on this slide, but this shows you progression to end-stage renal disease in years, and this shows you these different colored lines, how that progression looked based on how what stage of chronic kidney disease people had, but also whether or not they had much proteinuria. And this blue line that shows absence of progression were actually patients who were treated for a protein to creatinine ratio of no higher than 0.3. So I historically haven't really treated folks much below 1, but with this with this data out, I feel like I probably have to become a little more aggressive and treat even mildly elevated urinary protein to creatinine ratios. Now you're going to say, well, this is all adult data. What does it have to do with children? Unfortunately, the truth is that in this fairly recent review in the European Journal of Pediatrics, it's hard to see, very similar pictures and bold prints of proteinuria and renin-angiotensin system antagonism are shown for pediatric-specific chronic kidney disease. So this probably does apply to children as well. Now, you may be convinced that we need to be very aggressive in chronic kidney disease with proteinuria management, but then you're going to read this Cochrane review from 6 or 7 years ago for adults with early, stage 1 to 3, non-diabetic chronic kidney disease. And interestingly enough, this evidence-based review concluded that there is insufficient evidence to determine the effectiveness of RAS targeting in patients with this type of kidney disease and who are non-diabetic. Based on this review, one could still argue that maybe one doesn't have to jump on relatively mild degrees of proteinuria. And then what about more advanced chronic kidney disease? Once again, in adults. So this is a systematic review and meta-analysis very recently published of diabetics, adult diabetics with advanced chronic kidney disease, so stage 3 to 5, and even in those patients, according to this meta-analysis, the question of whether or not to prescribe or withhold RAS blocking agents cannot be answered with confidence based on the available evidence. So in conclusion, drugs targeting the renin-angiotensin system, or systems as we should probably say nowadays, should not be added to the drinking water, and they should certainly, more importantly, not be given to women who want to get pregnant. Using these drugs to treat patients with early chronic kidney disease and low-grade proteinuria may or may not help delay or even prevent progression to end-stage renal disease. And more generally speaking, we continue to learn about the complex network of renin-angiotensin systems, their physiological properties, and the effects of their pharmacological modulation. Thank you.